Hi, I'm Dr. Gerald Deas. Welcome to Health Center from Downstate Medical Center. Today we're going to talk about a very important thing that happens in one's life, and that's delivery of a baby, or taking care of a baby even before they're delivered. You know, years ago, people would come in 6 months pregnant or 9 months pregnant and just deliver, and that was the end of it, but not realizing that in that 9 months in between becoming pregnant and delivery is a very important time if you're going to have a healthy baby. In fact, it's even more important if it's a year before you're going to have the baby to take care of that body, because that baby has to stay in there 9 months and get all the nutrients and all the things that it has, care and things that it has to have a nice healthy baby. So we're going to talk about delivery of the baby, and also not only delivery of the baby today, but you out there who might be expecting a baby, that what you should be considering. You know, when I was at medical school here, I came here in 1958, Downstate Medical College, and I stayed on to Kings County Hospital in Downstate, and one of the men was Dr. Lewis Hellman. Dr. Lewis Hellman, he was the one that brought midwifery into this university, in the sense that he made it plain that you don't always have to have a MD to deliver a baby, but you can have a very well expert trained person that can do almost all of those kind of things, and if there's some difficulty, you call in the GYN doctor and things like that who would assist maybe in a difficulty delivery. But today we have midwifery here at Downstate, and we have with us today one of the persons who really sees that patient before they get pregnant and even after they become pregnant, and she's right here at Downstate, a person who trained right here at Kings County Hospital. So I want to welcome Gladys Christoph.
Hi.
So nice meeting you today, Gladys. Now tell me, before we get into you and what you're doing here at Downstate and Kings County, just a little bit of your background. What brought you into this whole thing of taking care of babies before they come?
My name is Gladys Christoph. I grew up in Brooklyn, and I went to Erasmus High School, and I went to Jewish Hospital, School of Nursing, Interfaith Medical Center.
Right.
I came to Downstate after I worked as a registered nurse for 7 years.
I see.
And while I work in labor and delivery, I had two midwives that really inspired me.
Okay.
And I also realized the need for someone to be with the patient other than the doctor. Because sometimes the doctors, they run the show and they're very, very busy. As a midwife, which incidentally, midwife is with women. That's what the definition of midwife.
Surely.
So we stay with the patient more. We talk to the patient. We get involved, just the way the doctor would.
Yes.
But sometimes when the floor is too busy, when they have other patients to attend to, which is always the case, us as midwives have more time.
Yes, right.
To spend with the patients. Hence, one of my reasons for becoming a midwife. I also had other midwives that have pioneered me and also encouraged me. The two midwives, they told me, "Oh, I saw midwifery in you. I like the way you talk to the patients, the way you treat the patients. I think that's your calling."
Yeah.
So I actually took their advice, and I came to Downstate Medical Center, Kings County, a midwifery school, which I enjoyed. And I also enjoy being a midwife. I love my patients. I love doing what I'm doing.
Yeah.
And now I'm at Downstate, where I actually graduated from, and it's like giving back to the community.
Well, that's
and
wonderful.
I love what I do.
Well, you know, but you have a lot of other people in the whole field of medicine too, and some of the other folks in medicine in your family.
Oh yes, I have my niece just graduated from Downstate 2 years ago, Downstate Medical Center. She's doing her first year residency in Arkansas now, in Tennessee. They moved to Arkansas. She's one of the doctors, and I have OB. She's doing OB. Obstetrics.
Right.
I think I've been one of her inspiration, because I always talk about OB,
right,
about my patients, about
right,
what I do, about Downstate Hospital.
Sure.
Actually, she wanted to come to Downstate, but her life took her elsewhere.
I see.
And she worked with the chairman, Dr. Abulafi, and she thinks the best of him. Everybody does. He's a funny guy.
Well,
He's nice.
well, you know, I remember her being here as a student, you know,
Yes.
just being here myself. I see so many students pass through here. But you have some doctors in your family, too.
Yes, then I have my 3 cousins. Actually, they much younger. They graduated one from Mount Sinai Medical School, one from UMDJ Medical School,
Yes.
and one from New York Medical College. Actually, my cousin, Dr. Deas, he graduated from, he's finishing his last year here
Right.
as an emergency medical,
Right.
yeah.
Well, that's great heritage. I mean, there's no reason for folks looking out here saying that they shouldn't encourage their young people to become doctors, midwives, and what have you. You know.
You know, I think they should. I think people do need other people to care for them.
Surely.
Community
Surely.
providers, either doctors, nurses, midwives. I think, and I have spoken to a lot of younger people who say they really don't want to do nursing or medicine. Reasons, they don't like blood. Okay, it's not really a reason, or the time. This is one of the main reasons. Oh, no, it takes too long. I said, well, you're 20. I mean, wow, you have a lot of time.
Oh, sure.
I can say I don't have that, but you do.
Right,
So I
surely.
try to encourage. Actually, I had a patient when I work at Elmer's. I used to do the teenage clinic at Elmer's Hospital. Up to now, I keep in touch with her. She wanted to be a doctor, and she got pregnant. Of course, she was 18, but we always talk. So I always encourage her. You know, you still can do whatever you want to do. Yeah.
Surely.
So she graduated medical school about 4 years ago. We still keep in touch. So
Right.
she did follow her dream, and I'm glad I was part of it. So we
Right.
talk all the time.
Now, being a midwife, give me just a sequence of how you handle a patient, or how the patient is first introduced to you, and follow through with maybe the delivery of that patient.
Okay. Right here, well, for every midwifery program, when the patient first comes to you as a new patient, and this is what we do mostly here, we see the patient as a new patient,
Okay.
usually low-risk patient. If there is any history of diabetes, high blood pressure, lupus, sickle cell disease, any kind of problems, the
Drug
patient
addiction.
is...
Even drug addiction.
Even drug addiction,
Yes.
yes.
AIDS.
AIDS, oh yeah, definitely.
Right.
They are referred to the doctor for high-risk MD management.
Right.
But right here at Downstate, we do have high-risk MD management, but the midwives, we see the new patients.
Right. Sure.
And the normal low-risk patients. And even throughout the pregnancy, if a problem arises, the patient is transferred to the MD.
I see.
Okay, we see the patient the first visit, we order the labs, we monitor the fetal heart, send the patient for the sonogram, refer her to every other discipline they have to be referred to, and give her an appointment, depending on what gestational age, to come back to see us.
I see.
Usually we will follow the patient until term. Until term. We do cover labor and delivery. However, the need for us is greater in the clinic.
I see.
So I've delivered some babies here before, but only during the time I am working in the delivery room.
Right.
But the time constraint, and
Surely.
we don't do calls.
Surely.
We do not do calls.
Right. But the main thing is that you're ensuring that this baby is a healthy baby.
Oh, we ensure that the baby is a healthy baby. We monitor the weight, the blood pressure, of course, the nutrition needs, the dietary intake.
Yes.
We do talk to the patients and their importance of keeping their prenatal appointments.
Boy.
Because if there are time constraint exams they have to do, we have to actually monitor them, sonogram, monitor the baby's weight, all the labs. So we have to ensure they're taking their vitamins. So they have to come constantly to the clinic, because when they come, we have to review everything that happened between the time of the last visit and our time, the time they're seeing us now, to see if there are any changes or any adjustments that have to be done prior, or if they have to be transferred to the doctor, if they have to have follow-up sonogram appointments, and everything.
Right, right.
So, but then it's not just that. We kind of we are also involved in their social lives. It's
Well,
like
that's what I was going to come to.
yeah,
Because many of them are coming from backgrounds that are very difficult.
And different.
And housing,
to housing,
where they live at, and
yes,
relationships to their boyfriend or husband.
Yeah, family members, anybody.
Surely.
We've had patients that live in shelters.
Oh, yes.
Yeah. So we have to refer them to social worker. They come from every different backgrounds. We also, this is why we are kind of high risk, because we have patients that come very late in the gestational age.
Right.
Very late. And
how
from
many
different
months,
countries.
How many
months? Oh, we've had patients at 34 weeks, 32 weeks, 34 weeks. In fact, one time I had a patient that came the first visit. She was 38 weeks. Mm-hmm. I consulted with the attending. We sent her to labor and delivery. And she had to be delivered the same day, that late. So
yes.
We kind of, because a patient like this, you really don't know anything about her.
Right.
But our job, with this kind of patient, we see her as a new patient and then talk to the attending. Yeah. And then these patients are managed by the attending. And they felt this particular patient had to be admitted based on certain other criteria in her health.
Right.
So,
well, you know, I can just see, just the connection, the feeling of someone who cares taking care of a baby. Sometimes doctors, like you say, have so much work to do, and they don't have the time to sit down and exchange really woman-to-woman talk sometimes, And woman-to-woman talk there's a book called Woman. I read this. I said that anybody that touches a woman in medicine or anywhere should read this book called Woman, because a woman has so many, they're different than a male, of course.
We have so many things in common.
So many things to cover, I mean, they're coming in, I'm sure they're asking you about sexual activity during pregnancy and things like this.
They ask about everything, sexual activity being one of them. Relationships, they even ask, sometimes they'll come and ask for letters for school for the other sibling. But then when you talk to them, you have a feel of what's going on. You do ask questions. So now we know who is with the significant other, who the significant other is maltreated, is not treating properly, who is in a witness protection program. It's when you sit and talk to them. We are lucky because we have the time to get this and to direct them to the appropriate channels.
Surely.
So it's also a social connection between the midwife and the midwife's patient. And we do see a lot of younger patients too. So it's like some of them call us mom. It's like we are like a maternal figure for some of them. Or for others, we are the confidant, we are the friend.
Sure.
And actually they don't have problems because for them not to be delivered by us. Because it's like the relationship is already established.
Yes.
So if they delivered, we'll go and visit them on the floor. We don't visit the baby and everything. So I think we're doing good here at Downstate with our patients.
Well, I did a lot of work here in sickle cell anemia, for example, and of course, and we started a whole organization called the Sickle Cell Victims Organization. And what we tried to do is make things comfortable for a patient who was in pain and coming to a clinic and things like this. And one thing I did, which I'm trying to institute in other departments, is that oftentimes a patient will come and they didn't have even car fare to go home, or they didn't have money for groceries that day. And I made it a point that I started a contribution thing where I gave the social worker who saw the patient that day a certain amount of money in bills to ask the patient, are you having a crisis right now in maybe paying an electric bill, or you need groceries or what have you? And they were instructed to give them, if they needed $50 even, to give them $50, and all the person had to do was just sign that they received it. Didn't have to go downstairs, didn't have to run around, didn't have to have anybody to question why they needed that $50, or $20 even, and things like that. $20 would mean a whole great deal.
Oh yeah, to someone who doesn't
a person who doesn't have a cent when they leave that clinic, you know what I mean? And I think this is where we miss some time. Although we give all the great care, we don't ask that financial thing for immediate financial help, not running downtown, not across the board. So all the monies I raised in sickle cell anemia was thousands and thousands of dollars. I was able to help patients when they came in with their children. They needed a coat or something like that for that child or something like that. So I started a whole nother thing and how we should be distributing monies directly to the patient rather than going through a whole lot of
channels.
junk. You know what I mean? Because people are embarrassed even to ask. So I always told the social worker to say, can I help you? Is there any need that you, immediate need that you have? And you'd be surprised at it. One time that anybody would ask for any exorbitant amount, or there wasn't a one time that they were not embarrassed almost to say, well, I need something to get home. You know, it's cold out, I don't have and I'm pregnant, and I need to get home. I got a child at home, what have you, you know. So that's another thing that I was very interested in establishing in our clinics to be more giving in that way to financial, because that can wreck a home.
But you see, we have, well, the social worker somewhat takes care of that, but not the financial.
I understand, surely.
But patients at times, they wanted car fares.
Car fare,
right.
Sure.
Which they have taken care of.
Yes, right.
MetroCard. They get MetroCard.
A MetroCard.
MetroCard.
Yeah, that's good, yes.
Yeah, and also the patients who don't have insurance, we're going to come to patients who don't have insurance, they are, if they need medication that we don't have in the clinic, they are sent to the pharmacy to get the prescription. But now we also have the pickup program now. This is why we have a lot of patients. There are a lot of times, even in this community, some patients will not come for prenatal care because they don't have insurance.
Right, sure.
So they will just come and deliver their babies.
Yes.
So now our need is to put out the word that they have pickup. Whether you have green card, you are a legal alien or illegal, it is available for everybody.
That's wonderful.
Yeah,
that's wonderful.
It's a prenatal, pickup stands for Prenatal Care Assistance Program.
Okay.
It's here at Downstate, and I think it's the best.
Well, I know a few years ago, I was in a conference, and someone named Miss Brandon got up to talk about prenatal care and things. I didn't know Miss Brandon at that time, but after the conference, I went over and met her, and she said she was here now to start a program as such, and we became friends from that time on, and she has done, where a clinic was only seeing a couple of patients, all of a sudden it exploded like a flower.
Yeah, she goes out there. Miss Pamela Brendan, she's the one actually responsible for this program.
Yeah.
Yeah, and we have seen an improve.
Yeah.
An improve.
Because
now they know.
They know.
People are knowing. We just need to we introduce more people to it, because I've met people who don't know, people that don't know anyone, but now each one tells the other the word.
Yeah, sure.
They're passing on the word. Oh, no, you don't have insurance. I had a patient that came to see me actually and said, no, someone told me I can come in without insurance and without a green card.
Right. Welcome.
That's how it is.
It's wonderful.
Pass the word.
There you go. When they talk about uninsured people and things like that, people all of a sudden...
That counts because pickup includes the prenatal care, all the labs, the sonograms, which they love, the sonogram, and the delivery, all the follow-up.
Yes.
And they get the insurance. They are covered from the day they come in the clinic.
Yeah.
Until 6 weeks after the delivery.
Isn't that wonderful?
And the babies get their insurance too. The babies get their medical card even before they're born. They usually send the card to the mom.
Now, if they could do that with adult medicine, we'd be in good shape.
I think maybe you should.
Somebody should be following this plan.
Yeah.
You should go to Barack Obama and say, hey, President Obama, we have a program that's going very well and being taken care of persons who can't afford to take care of a baby after during their pregnancy and things, to get healthy children, healthy babies, because so many things can happen in the interim. Even abortions can take place because people feel there's no end to it, so I'll abort or what have you. They have no choice.
Yes.
At a particular point, you may say, well, abortion is terrible. But when your back is to the wall, and you're carrying a baby with all the discomfort, and carrying a baby is not comfortable.
No.
It's not
and all the social issues, sometimes physical, emotional. So it is important for them to know they can get the medical coverage.
Sure.
Plus, they're getting the best care. I think
Best
we do
care.
the best care in Brooklyn. I think this department is
Don't say
doing great.
Brooklyn. How about New York?
In New York, yes,
Okay.
yeah. I think this department is great. I think we have the best doctors, from the chairman, the vice chair.
Your chairman of your department is?
Dr. Abulafia.
And
Dr.
I imagine he
Abulafia.
has really added to the program.
Yes, yes, yes.
He's the chairman here at Downstate
Quite a
Medical
lot.
Center.
Yes.
Yes.
And we have the perinatologist, Dr. Scherer, who
Oh,
does
yeah, I've been to that one.
who does the best work in sonograms.
Oh,
I mean,
my gosh.
he's very passionate about what he does.
And I've seen
So-
babies come in about big as my hand or smaller than my hand.
And
you have a tremendous program there to take care of those babies.
oh yes, oh yeah. And this is why it's not, thank God, this prematurity is not so common here.
Right.
Because of the care we provide.
Yeah, that's right.
It's very important.
Because think of the cost of the premature
oh, yeah.
baby.
Oh, yes.
I mean, it's thousands and thousands and thousands of dollars of caring.
Premature, yeah.
Premature
so this
baby.
is one. This is the goal. This is one of what the goals of what is going on here.
Right.
And it's emphasized on every provider. We are here for the mom and the
Right,
baby.
sure.
We have to ensure that they get the adequate health.
Right.
And at the end, we want a healthy mom and a healthy baby.
Yes.
And this is what they're striving for, and this is what is so great about this department.
Well, you know, when I was in Detroit, they had a program that when the baby was born, they would even have a midwife or a person equivalent to that to go and see the baby at home, say for at least a couple of weeks after the baby got home. Because that in itself is survival too, because that first 6 weeks or whatever at home could be horrendous for the life of that baby.
See, we have the midwives per se don't go, but they
Right.
have the visiting nurses.
That's right, yes.
If the need arises, they have patients that they have referred visiting nurses to,
Right.
who follow to the mom after they
Sure,
delivered home.
surely,
Oh
surely.
yeah, we have, and especially preemies, if they have any babies with any kind of problems, or they do have
Right.
visiting nurses,
Right.
not midwives. because-
And what do you see the future for young persons like yourself? Are there male midwives?
Oh yeah, they have, and they are called midwives also. Yeah, they have not as much as the females, but they
Right.
do have male midwives.
But they can also train as well as a female.
Oh,
for a
yes.
midwife,
Oh, yeah.
I think that's wonderful too.
Yeah, and we precept students. We have a lot of nurse practitioners we are currently precepting.
Uh-huh.
Oh yeah.
Well, I tell you, the whole department here has exploded over the last few years to, I don't know how many babies you see in a year's time. Do you have any idea how many?
See or deliver.
Well, both. When I say see as a midwife.
As midwife, probably more than 400. We
400.
see babies regular. Yeah.
Yeah, right,
Mm-hmm.
right. Well,
We see them.
that's a tremendous help to the community.
Yeah,
You know.
we see, and we are actually encouraging them to come more when they have the health fair. When the health fair that is sponsored by the hospital, I try to bring on the papers, encouraging people to come. We've been to Brooklyn Midwood High School
Oh,
recently.
yeah, right. Oh, you went to the schools too.
Yes.
There's
Oh, yeah.
two kind of-
No. When we had the health fairs.
Oh, health fairs,
Oh, yeah.
right.
Probably this is one thing we are going to discuss, whether we should go to schools, to the high school, to recruit and to speak to some of
Oh,
these
yeah, I think
patients.
that's so important.
Yes.
Because they have all these different high schools now that are broken up into different levels,
Yes.
different interests.
Yes.
I think it's be so important that you could get a whole host of young ladies or young men that might be interested in coming into that field.
Yes.
And tell them how to start off to get their RN or whatever and things
Oh, yeah.
like this.
And they ask. We have some patients that are impressed with what we do.
Right.
We laugh with them a lot. It's like we're a family.
Right.
And they ask, well, how long does it take to become a midwife? So it's always a pleasure
Sure.
to say, okay, you want to be a midwife? Okay, then we go on the steps. But now they don't have to be registered nurses to be midwives anymore. I was a registered nurse before I became a midwife.
Right.
But Downstate has this program. If you are a registered nurse, that's fine. But they have this program now. As long as you have a bachelor's degree, you can become a midwife.
Oh, that,
They-
yeah.
You're trained.
Oh, that's wonderful.
Yes.
Well, Ms. Christoph, it's been a pleasure just given this shorter time. I know it took a long time to get to where you got, but a short time for information that is so invaluable. I mean, to what our listeners should hear of what you're doing at Downstate Medical College here, right here in the midst. Like I said, I've been here 52 years this year, and I said, just to see all these different things happen during the time, because it wasn't like this years ago, you know, and to see what you're doing is just wonderful. So continue the good work. Try to encourage other young ladies to come into it. Go out to some of these high schools and things like that and let them just give a background of some of what you're doing here. And I think that role model is so important for our young ladies,
Yes.
you know. And it's just a pleasure having you.
Thank you.
Yeah, and to you
Thanks.
folks out there, remember there's right here at Downstate Medical Center, there's this midwifery clinic that you can come with your pregnancy and it be ensured of a good, healthy baby and a good, healthy neighborhood. And remember, they take care of everything, all the expenses having to do with this, all the examinations and things like that. See you next.